Alex Miller, and I'm with the Ohio AAP, and we want to thank the Ohio Department of Health for their support with this program. I will now stop sharing my screen and let Steph share hers.
Oh, I was going to say, actually, since I'm on a different computer, if you wanted to keep sharing, that would be very helpful for us.
Yes, let me find the other slides.
Oh, no, okay, I'm able to. I'm sorry. For some reason, the system was not working for me today. There we go. All right. I'm able to now. All right. And Alex, I'm sorry, did you already go through these beginning slides?
I haven't yet.
Okay.
Great. So our next training will be on trauma-informed care and ACEs on April 8th. We have new resources that are available, and I will put the link to the website in the chat box. And then we also have a QI program coming in January of 2022. So if you're interested in participating, please let me know. Next slide. And we also have a provider and family resource that is available based on the content of this training. We also have the family resource translated into Spanish. So I'll put that in the chat box as well. Please, throughout the training, keep your lines muted and your cameras off, and speakers will take questions at the end. And please let us know if there's anything that you need throughout the training in the chat box. I will go ahead and pass it over.
Great, thank you so much, Alex. We are really excited to be here today to talk about the CDC's Learn the Signs Act Early program. And our focus is on acting early to promote child development and the 4 steps of early identification. And when we talk about early identification, that's not just referral to early intervention in Ohio through our Part C program, but all early intervention that would include any type of referral based on a positive screen for a developmental concern, to comprehensive evaluation, or to any type of the therapies that the child may need. My name is Dr. Steph Weber. I'm a clinical psychologist at Cincinnati Children's and the Act Early Ohio ambassador. And I'm here with my colleagues today who will introduce themselves. Just a little bit more about the Act Early Ambassador program. All states and most US territories now have an Act Early Ambassador that works as a champion for developmental monitoring and screening with the CDC's Learn the Signs program. My contact information is there, and we'll talk a little bit more at the end about our Act Early Ohio program.
Hi, everyone. My name is Pam Williams-Aria. I'm a developmental behavioral pediatrician at Cincinnati Children's Hospital, and most of my clinical practice is seeing, evaluating and managing children with developmental delays and disorders, as well as concerns for autism spectrum disorder. I am the pediatric faculty for the LEND program here, Leadership Education in Neurodevelopmental and Related Disabilities. And in the first part of my career, prior to going back and doing my specialty training, I practiced as a primary care pediatrician for almost 10 years. So this is a topic today that's near and dear to me.
Hello, everyone. My name is Olga Riddle. I also work with Dr. Williams-Aria and Dr. Weber at Cincinnati Children's Hospital. I'm an associate professor there and also the director of the University of Cincinnati Center for Excellence in Developmental Disabilities, sitting within the Division of Developmental and Behavioral Pediatrics. And as part of the position with the University Center, I work on making sure that families and children receive the services and have the information about the services that are available to them in the state. So I'm really excited for this opportunity today to share a little bit more about Learn the Signs Act Early, as well as early intervention and home visiting.
The only financial disclosures we have are that a small portion of Dr. Riddle and my salary FTE is on a CDC COVID-19 response grant that we're working on through the Ambassador program. Today, we kind of broke it up into these 3 main areas. We're going to talk about the 4 steps to early identification, as well as the strategies for incorporating monitoring and screening into a well child visit, particularly incorporating the updated milestones that were released last month. and then identifying those resources that are available throughout Ohio for early intervention and home visiting, as well as comprehensive evaluations and therapies.
So developmental concerns are important because they're so common. The CDC estimates that 1 in 6 children in the United States have a developmental disability, but less than half are identified before they enter kindergarten. And this delay in diagnosis puts children at risk for increased difficulties with behavior problems, academic issues, as well as chronic health conditions. Next slide, please. Developmental disorders are diagnosed as or defined as a group of conditions characterized by impairment in one of a number of different domains, including physical, learning, language, or behavior areas, and they result in functional limitations in major life activities. Next slide, please. Information that we have on the prevalence of developmental disabilities comes from the National Health Interview Survey, which is a national representative sample where parents are asked by survey as well as by interview whether or not their child has been diagnosed with one of 10 developmental disabilities. And these include the ones they're asked about are ADHD, autism spectrum disorder, blindness, cerebral palsy, deafness, hard of hearing, learning disability, intellectual disability, seizures, stuttering or speech difficulties, as well as a category of other developmental delay. And this was published in 2019, and this prevalence data is from the years 2009 to 2017. Next slide, please. So what we found from this data is that the prevalence of some developmental disabilities has increased. ADHD, autism spectrum disorder, and intellectual disability were all increased. But importantly, there was a concomitant decrease in the prevalence of any other developmental delay. So that kind of last category that families are asked about. And we'll talk about a little bit more in a bit. But when we look at this table that's taken from that publication, we just wanted to point out a very large increase in the prevalence of autism spectrum disorder. And we'll talk a bit about why that may be as well. So that jumped up 122% between those interval years. Next slide, please. So there's some variety of reasons why we may be seeing an increase in the prevalence of developmental disabilities in the United States. And one is better identification over time. So parents and families may be aware of there's just better awareness, social media, other outlets about developmental disorders. And so they may be seeking evaluation or bringing up concerns more readily. There also has been changes in provider practices like universal screening and ongoing monitoring, which we're talking about today. So this may have also resulted in identifying children more and also being able to identify children more specifically. So diagnostic substitution from that category of other developmental delay, very non-specific, to a more specific developmental disability. In addition, there have been some changes in diagnostic criteria, most notably around the diagnosis of autism spectrum disorder, with some broadening of that definition with subsequent revisions of the Diagnostic and Statistic Manual. And then wording of questions themselves. So from that interval time period in the publication from 2009 to 2017, there were some changes. For example, in 2011, one of the questions, the wording was changed from asking families whether or not their child had been diagnosed with mental retardation to asking about whether or not their child had been diagnosed with intellectual disability, which families may be more willing to endorse. Next slide, please. I also meant to say that there may also be some true increase in prevalence of some of these developmental disabilities, and that's being studied as well, but a variety of reasons why prevalence may be changing. Developmental disorders may present in a variety of different ways, sometimes observation at a office visit, whether that be an ill visit or a well-child check. There may be some notable things that kind of warrant further investigation and kind of prompt something happening or something being noticed. And then also parents themselves may, through a phone call or making a visit or during some other ill visit or well-child visit, may bring up concerns about their child's development. And this is important because parental concerns often precede any detection in the office. So when parents are concerned, that is definitely something we want to pay attention to. Next slide, please. So as far as like addressing concerns from families, prompt referral to early intervention is typically the first step. And there are a couple of reasons why that is, and to other indicated therapies and interventions. But the reason why it's so important to do that as soon as possible is because it's helpful to be able to take advantage of very young children's brain plasticity and adaptability and getting kids into those interventions and that are going to be most likely to be effective for them. In addition to that, giving family those tools, that support, that understanding of their child's difficulties, and helping them to have a roadmap for feeling more confident as their child enters preschool, as they enter other educational settings, and also helping them connect with community resources and support networks. Next slide, please. A couple of developmental disabilities I wanted to address specifically are global developmental delay and autism spectrum disorder. These are two developmental disabilities that occur with a high enough prevalence in the population that all primary care providers can expect to see them in their office settings with some degree of frequency. Next slide, please. Global developmental delay, by definition, is a significant delay in two or more areas of development. And those can include motor, language, cognitive, personal, social, and those activities of daily living. And it implies deficits in both learning and adaptation. And if those delays are to persist over time, then it may predict a later diagnosis of intellectual disability. This diagnosis is typically reserved for children age 5 or under, after which time IQ testing is more reliable and the diagnosis is able to be more specific. And the prevalence rate is felt to be about 1 to 3% in the United States population. Next slide, please. Autism spectrum disorder is a neurodevelopmental disorder with deficits in two areas, and those include impairments in social interaction and social communication, as well as behavior patterns that are restrictive and repetitive in nature. It's diagnosed 4 times more commonly in boys than in girls, with an overall prevalence rate of 2.27%, which translates to 1 in 44 children in the United States. Next slide, please. The information that we have on prevalence of autism spectrum disorder comes from the Autism and Developmental Disabilities Monitoring Network. Right. This publication is from 2021, and the data is from 2018. And the Autism and Developmental Disabilities Monitoring Network is an active surveillance survey or study that actively obtains information from 11 different sites, and those include both rural and urban locations. And information about diagnoses of autism spectrum disorder is reviewed and abstracted from both medical evaluations as well as educational data, but it undergoes a secondary review by a experienced clinician to make sure that these cases meet the definition of autism based on the DSM-5. Next slide, please. It's important also to keep in mind, as we talk about the prevalence of developmental disabilities, that children from minoritized backgrounds are at risk for late diagnosis, and there's a variety of reasons for that. Reduced access to healthcare being one of them, distrust of healthcare in certain cultures, non-citizenship, and low screening rates, lack of cultural knowledge of developmental disability, stigma in certain cultures that may reduce families' willingness to bring forth concerns, English not being the primary language, which leads to some barriers, and then inequities in healthcare due to racial discrimination or ethnic discrimination. And so it's just important to keep that in mind too, as we're talking about prevalence of developmental disabilities. And next, I'm going to turn it over to Dr. Weber, who's going to introduce us to the steps of early identification.
Yes, thank you, Dr. Williams-Aria. So the main steps of early identification of young children with developmental concerns begins with engaging the family in the developmental monitoring process. And monitoring and surveillance are used interchangeably throughout the research and throughout common practice. And so obviously in the medical field, surveillance is used more often, but most of the time when we work with community providers, childhood educators, and families we talk about monitoring or keeping a close eye on. Then that moves into the developmental screening process, which is oftentimes done in a well child visit, as well as if a child is in some sort of Head Start or early childhood education center. Then any positive screen would lead to referrals for needed supports and services. And then finally, our goal is having children receive the needed services. As you can probably imagine, there are many barriers both between and within each of these steps. And that's what a lot of the Learn the Signs Act Early work aims to do, is to help mitigate barriers and facilitate success of increasing developmental monitoring and screening across the board for all people who are interacting with young children birth to 5. So again, surveillance and monitoring are used interchangeably, and those are the long-term process that begins at birth, looking and watching for child developmental milestones. Screening is more of that standardized process, folks that are trained to use standardized tools at particular ages to identify any positive developmental concerns. And then evaluation is what we would typically think of that is happening more at one of our Ohio children's hospitals or clinic-based centers. That's more of a complex process, usually interdisciplinary or multidisciplinary, looking at specific domains of development that might be impacting the child. So I'm going to go forward in talking about that first step and ways in which that we as Learn the Signs Act Early have materials and strategies to build into your clinic practice. So what we know is that we want families to be able to communicate with all people who interact with their child, whether it is the early childhood care professionals. So we do a lot of work out in the community, educating those Head Start preschool teachers, childcare providers, center-based folks, home visitation, on having these conversations and empowering families to bring their concerns to you during the child's medical visit. We always encourage an early return visit to the pediatrician or doctor if there are any concerns that are brought up by the family that even may not be confirmed by screening. We want to keep a closer eye on those kiddos, particularly because we know that there is a significant delay between the time that parents initially have an inkling of a concern and then the time that they report it, and then the initial assessment in the doctor's office, and then particularly the time frame that it gets on a wait list into treatment. And sometimes that initial delay to the time when a child is enrolled in treatment can be up to a year or more. So we miss prime developmental experiences that could be supplemented through evaluation and assessment, as well as treatment. One of the main things that we're excited about sharing today is the pediatrics article that was put out in early February by Zubler and Associates. This is a group that worked on updating the developmental milestones that had not been updated since 2005. There's a wonderful video that goes along with this pediatrics article given by Dr. Zubler, just giving an overview of the entire process, and just want to throw in a couple key things that we're hearing. The process began in 2017 and ended in 2019. So all of the materials and everything was being created and finalized before the pandemic. So none of the changes have anything to do with COVID-19 pandemic or masking in children and adults. Additionally, there are it's evidence informed because there is simply not enough research or normative data in many areas of development, especially social emotional concerns, to warrant an evidence-based description. And so much more research and normative data needs to be identified before we can really say that these are evidence-based. But really, the milestones are meant to be health communication tools rather than guidelines, and they're by no means meant to be used as screening tools. These are links, and the reason that I have it both in English and Spanish is to just make sure that you are all aware that all of the materials are available in English and Spanish. There are also a number of other languages that the materials have been translated into, but not all of the materials. Only certain materials are available in other commonly spoken languages. Developmental milestones are the kind of the crux of this initiative. And as you can see, there's many different ways in which that communication of developmental milestones is done. So we have a partnership with vroom.com, which is a text-based and website-based brain building tip generator. We also have these really wonderful brochures that open up and look very similar to what Alex showed there at the beginning. And so it's been a really nice partnership with Ohio Department of Health and Ohio Developmental Disabilities to really make sure that we're all having the same message of act early. Additionally, there's checklists available at different age ranges online that caregivers can print out or you can use in your practice. One of my favorite pieces of material is a smartphone app that is available through the App Store for iPhone or on Android through the Google Play Store. It has been updated. It also corrects for prematurity, which is a wonderful feature. And again, you can toggle between English and Spanish. Other great features of this that are that you can put in a child, the family can get a reminder of when to track the milestones. They also have really wonderful tips and activities, and then questions that families may start to come and ask you in their well child visits. They can also get an email of the checklist emailed directly to you with a touch of a couple buttons in the app. So it's really wonderful and comprehensive. Other really great aspects of this initiative are these children's books. And you can see that the 1-year-old book here in English and Spanish. There's also children's books for 2-year-olds and 3-year-olds. And they've been developed so that anything that the character is doing in the book is what we would expect a 1-year-old, a 2-year-old, or a 3-year-old to be doing. And those are really, really popular with families, especially. So having some of those available in your clinic offices or to hand out at well child visits could be a really nice addition to getting families excited about monitoring development. So in general, using these materials, using these free app, as well as having just things available in your clinic spaces, on the walls, at the check-ins, can be really helpful. We have learned, and we'll tell you a little bit about this later, that at the beginning of COVID, families did not want to pick up anything due to all the concerns around COVID transmission. So we have an opportunity for you to order toolkits where we pre-package these materials into bags and you can hand them out directly to your patients' families. The other option is to work with us to create any type of brochures or posters for your walls that could be screenshot or used with QR codes so that families can be linked directly to the materials. I'm going to end my portion here about monitoring with a quick video, and hopefully, let me make sure that the sound will work. And Ilka or Pam, if you could just give me a heads up that the sound will work here in a second.
Healthcare providers know a lot about developmental screening, but having this tool, Learn the Signs, Act Early, really helps families to do the best developmental surveillance that they possibly can for their children. Learn the Signs, Act Early tools are fantastic, and they're free, and the CDC does a great job to really make sure that your patients are on target in their development. And that's really what we want to do, is make sure that in between those visits, the parents have the tools and resources that they need. Parents do get concerned and they don't know what to say or what to do, and having these resources like the app that shows them ways they can make a difference and see progress. Some of my favorites are the books, The Amazing Me and the Where is Bear for 2-year-olds. The Amazing Me is for 3-year-olds. When you have something tangible in your hand, it's always fun, especially at the 2- and 3-year-old visits, to really show the book to the child interacts with the book. Having that resource to give our patients as they're in the exam room and show parents how to use the book really makes a difference. It gives them ideas of how to interact with their children and really monitor their development. Having the tools is a reminder as a physician, this is important. We really need to talk about this. Parents want their children to be the best that they can be, and we need to be there to guide them.
So hopefully that helps you understand a little bit more about ways in which that you can build in the monitoring. Now we're going to get into that second step of early identification, which is the actual screening process. And I know this audience is well versed in the AAP guidelines, but as a reminder, surveillance should be done at every health supervision visit. And those standardized validated tools should be administered at 9, 18, and 24 or 30-month visits. And the ASD specific screening, such as using the MChat, should be done at the 18 and 24-month visits. And concerns at any point should trigger for a screening or referral or definitely an early return. The AAP does not have a specific list of validated measures that they endorse, but rather recommends using tools that cover all of these domains that go along with all of the general domains of development. So the motor, language and communication, problem solving and adaptive behavior, which really leads at that cognitive skill development and later IQ, and then personal and social skills, which really gets at the social emotional development. It's really important that the tools also be culturally and linguistically sensitive or provided in the language of the family's native tongue. Some common screening tests, and we've listed those here that we hear a lot or that we talk about with great use, are the ages and stages. It's very short and it has pretty decent sensitivity and specificity. The PEDS is also very quick. The SWIC is being used more and more throughout the country, and it is 5 minutes or less, and it's free online as well as free scoring and very easy scoring online. And then I mentioned the MChat, which is the modified checklist for autism in toddlers that is done more specifically to look at autism symptoms. This is just a final summary of looking at the overlap of monitoring and screening. And again, I can't emphasize enough that the updated developmental milestones that have been put out by the CDC are not in any way intended to be screening tools, but rather supplemental materials for monitoring and those communication tools that families can bring to you and say, this is what I'm seeing at home. And you can ask them the questions in response to get the conversations going around what the needs are or what the successes are too. That's really what we hear from families, is that we want to have our child's developmental successes be celebrated in addition to focusing on what may need to be supplemented with services. This has also been researched recently in terms of combining developmental screening and monitoring through some groups at Georgia State and the CDC. And we found that when developmental screening and monitoring are done together, children are more likely to be identified for early intervention and receive those early intervention services compared to screening alone, monitoring alone, or none of them. This was also followed up that we saw that same association with receipt of preschool special education. So when children age out of the early intervention system and move into their school district system at age 3, they're more likely to receive special education services if screening and monitoring had been done together. They've also looked at this across race and ethnic groups and find that screening and monitoring, again, as I can't say it enough, putting those together are also helpful when identifying children of non-white groups. And finally, we have one study that looks at provider responses and what is the action step as a result of positive developmental screening. And there are disparities that we've seen in this area, particularly related to white children are identified more readily through monitoring, whereas non-white children are more likely to be identified at time of screening. And so we really want to emphasize that just how important both are, but particularly screening for those minoritized populations, given that oftentimes it does take that positive screen to lead to action and referral. And now I'll send it back over to Dr. Pam.
Okay, thank you, Dr. Weber. So the most recent guidance from the AAP on identifying infants and young children comes from, it was published in January 2020 and is a revision of the previous 2006 policy. And it includes an algorithm, which is a nice kind of visual process for kind of steps to take. And then also it includes a link to a supplement, which, as Dr. Weber said, AAP doesn't endorse any specific screening tool, but the supplement to that article also includes like a list of all the different available screening tools and their different processes and so forth, different metrics about them. However, the screening of, previous slide, please. The screening for the developmental disabilities also is just part of a broader universal screening recommendation from the AAP. So it just fits into that broader AAP model, which also includes screening for metabolic disorders, hearing loss, vision problems, as well as behavior and emotional problems. Next slide, please. So we know that without screening, 50% of children won't get identified until kindergarten, which puts them at increased risk for behavior difficulties, academic problems, as well as chronic health conditions. Next slide, please. The AAP has some information about trends in pediatricians' developmental screening through the AAP periodic survey that is sent out. And this was published in April 2020, but includes data from 2002 to 2016, which also asked pediatric providers about barriers to screening, which is helpful in trying to come up with strategies to mitigate those barriers. Next slide, please. Rates of developmental screening that were uncovered in that publication include improvement from use of developmental screening tools from 2002 at 21% to 63% in 2016. And over that same time period, an increase in pediatricians referring at-risk patients to early intervention from 41% in 2002 to 59% in 2016. So this data is very encouraging, but as you can see, there's still quite a bit of room for improvement. Next slide, please. Another way of looking at screening for developmental disabilities is we get information from the National Survey of Children's Health, which asks caregivers about their children who are aged 9 months to 5 years and whether they were asked at visits, if a doctor has asked them use of a questionnaire and asking them about their child's development and specific concerns around communication, social behaviors, and other developmental areas. And from this data, about 37% nationwide of caregivers endorsed that their provider had done screening, which mirrors in Ohio, mirrors what we see here in our state. And I think this is telling that probably caregivers aren't aware that screening is taking place. I think it's important information to have, or they don't feel like they are included in that. And so I think maybe considering to make that, call that out, that that's what's happening, so that families feel like they're involved and that screening is happening. So anyway, I think it's just helpful information for providers to have. Next slide, please. The AAP has come up with a variety of strategies to help primary care providers implement screening into their offices, because they have asked pediatricians about those barriers. And we'll talk a little bit more specifics about some of the materials that are out there in an upcoming slide. But some of the strategies include just trying to use the whole office. So implementing this system, not just among a couple of people, but the whole office being involved as a team. And considering starting the process either in the child's home, like getting the materials to the families ahead of time to start filling out, or at registration, handing things to the family there. Again, dividing that responsibility among staff. So it's not just the provider involved or 1 or 2 people, but maybe there's multiple people involved. And then whatever process is chosen by the office, to kind of update and actively tweak that system to try to make it as seamless as possible. Trying to choose, there's so many screening tools out there, trying to choose the one that is going to be least disruptive to your specific clinic flow. And then the scoring afterwards, trying to maybe train somebody that's a non-physician or non-clinician to do that scoring. So again, that's one less thing that the provider is doing after the visit. Next slide, please. The AAP is really invested in helping primary care providers in this, and they have developed a lot of different materials. They have listened to clinicians who have shown interest in learning more about identifying risks, strengths, and protective factors for kids and families. So there's material on that. There are 2 free Prevalenc courses there's one on surveillance, and there's also one on innovative strategies for improving developmental surveillance and screening. And these both provide CME credit or MOC credit. I took the one in the bottom middle there, those innovative strategies, and I thought it was excellent. And it gave all kinds of like hacks and strategies for adopting some of these things into practices and meshing them in practices to make it seamless. And then there's also some material for families to help them navigate the referral process once a developmental concern has been identified. Next slide, please. So the next step in that early identification process is referring kids for those needed supports and services. And when concerns are identified, often our first step is going to be prompt referral to early intervention, and then specific referrals depending on what the concerns are from families. And then importantly, coming up with some kind of a plan for a follow-up or early return visit, specifically to discuss those concerns again, and making sure that families have connected to early intervention or have connected to those other referrals that have been placed, and finding out, are there additional concerns? How have things progressed since the last visit? So very similar to how any kind of medical issue would be managed in the medical home, to follow up and just update and see what's happened and allow families to ask questions. Next slide, please. The management of developmental disorders includes referral to evidence-based therapies, educational planning, connection to community resources, and then follow-up and surveillance for any co-occurring conditions. And the slide here is a picture. This is an example that we developed at our institution. It's for a community practice support tool, which is intended for our local primary care providers here to help them to navigate managing developmental disorders in their medical practices. And this may look different throughout the state. There's a wide variety of different resources and referring institutions. So this may look different depending on your specific location, but in that Prevalenc course that I referenced earlier, the one that I took on innovative strategies for surveillance and screening, they talk specifically about this, and everybody developing their own kind of resource plan, resource community for referring therapists and hospitals, specialists. And so this may look different depending on where you are, but is helpful for any location to have. Next slide, please. The community practice support tool that we developed here, and we just wanted to show this as an example of what this might look like, and it's going to look different in different places, but ours included an algorithm which we hope will help just visually our local providers with what are the next steps, what is the flow in this process when a developmental concern is identified. And that includes referral as soon as possible to early intervention, and then referring any child with a speech or language disorder or difficulty to audiology to rule out hearing loss, referral of children with behavior challenges to behavior therapy if it's a significant and disruptive concern, and also referral to, in our area, to a developmental behavioral pediatrician for concerns for global developmental delay or autism spectrum disorder, and referral to other specialists such as neurology or genetics as indicated, depending on what the concern is, and that this algorithm helps kind of like tease out exactly what that process would be, but just as an example. Next step, please. Next slide. Initiation of evidence-based interventions and therapies at as young an age as possible has been associated with improvement in both short and long-term outcomes. So the wait and see approach is not recommended, and I hope we've been able to emphasize that through this talk. And with that, we're going to turn it over to Dr. Riddle, who's going to talk about early intervention and home visiting.
Thank you, Dr. Williams-Aria. And thank you for the opportunity to talk a little bit more now about the resources that are actually available in our communities. So first, I'm going to talk about early intervention, and then I'm going to talk about home visiting. And if you think about Ohio, really, it's kind of like the Help Me Grow program is kind of like the umbrella for both early intervention and home visiting. So this is just the link to the Ohio Early Intervention website. I cannot emphasize enough how easy it is to kind of navigate that website. It has great resources and background for medical providers or other healthcare providers, and wonderful resources for families, especially once they have started the process of referral. Next slide. So one thing I wanted to point out is that there is actually a list of qualifying conditions called Appendix C. You have the link in the slides that you can click on. The one thing that we wanted to draw special attention to, because I think there was a change in 2019 or 20, is to look specifically what are some of the qualifying conditions for early intervention, and added to that was lead level of 5 micrograms per deciliter or greater, as well as neonatal abstinence syndrome. So that qualifies children for early intervention services, in addition to others. So talking a little bit more about EI, EI is made available to every eligible child and family in every state. And to point out, focus is really on the naturalistic setting of the family and the child. So the child is being met where the child lives. So the early intervention may happen in the home of the child. The family may meet at a park with their early intervention staff or team. They may, come to the child care center in which the child, is during the day. So it really, the focus is really on being in a naturalistic setting. And currently there is somewhat of a model depending on who your provider is. Some services are still provided virtually. Other providers are back to in-home or in-person. So it really depends a little bit on who your actual service provider is. And then the nice thing about early intervention, so if you think about it, it's 0 to 3, and then at at the age of 3, the referral happens to Part B. And so there is great support in the transition from going from early intervention into the school-based services. And the child moves up from an individualized family service plan to an individual education plan for the child that then will continue throughout their school years if needed and necessary. Not all children do transition to an IEP. So there are children who have services in the 0 to 3 service model and transition out because we have caught their developmental delays early and were able to address their concern. So they may just transition out and do not need necessarily services in the school-based system. Next slide. So early intervention happens kind of in steps. So the first step, and I will talk a bit about this a little bit later too, is the referral to early intervention. Anybody can refer. So the parent can self-refer to early intervention if they have a concern about their child. So they don't have to wait for their physician or another teacher to refer them to early intervention. So families can do that themselves. Once a referral has happened, a family will be contacted by intake for early intervention, and then there will be eligibility established for the child. So looking at if the child actually qualifies for early intervention services. I also know that children who do not qualify for early intervention services still usually receive some information how they can better support their child in their in reaching their developmental milestones. Then it's followed up with a process of assessment to determine what type of services the child needs and who the kind of team is for the child. And then an individualized family service plan is set up that includes specific goals and objectives for the family as well as the child. And then early intervention services are provided. And when the child, transitions over into the school-based services, the early intervention helps with that process to transition from Part C to Part B. What's really important to, next slide, sorry. What's really important to understand is the difference between early intervention and other therapies. So we get that question a lot in terms of why do I need early intervention if my child already receives kind of therapies in a clinical setting, in an outpatient setting. And the early intervention is really a coaching model. So it really it happens in the child's home, in the child's naturalistic setting. It is to help parents utilize what they have in their home or what's in their community with the children's toys to help them support their child within their development and to address some of the delays that the child has. It is not a therapy program. So it really helps to, if the child does something in therapy, to really translate that also into the naturalistic setting of the child, so that the child can actually do and the family can do what they would do in their regular typical day and integrate some of those supports that can help the child with development. Next point. Can early intervention be offered in the family's preferred language? Absolutely yes. Early intervention is offered to all children that qualify. And there can either be an in-person translator or a phone translator, as well as a Zoom or other model of interpretation if it's not in person. So how has COVID-19 impacted in-person services? Just like many other services, at some point early on, COVID-19 really put a big dent into in-person services, and many providers switched over to virtual services, providing the families with information and tips, doing kind of telehealth visits in terms of helping families figuring out what they can do with their child and walking the family through, again, providing coaching to the families in how they can provide the support for their child that their child needs. And as I mentioned earlier, depending on the service provider, at the moment, there are some services that are still provided virtually, others are back to in-person or some type of combination of those. Next one. What happens when I know I've referred a patient, but they are not yet getting early intervention? That's a great question. So with like many other things, I think families sometimes need multiple referrals before they actually make that step of going into early intervention or having their child assessed. There are many different reasons for that. If you go to the next slide, Steph. Okay, go back to the slide, sorry. I thought I had another slide in the beginning. So there are many different barriers for families why they may or may not act once their child has been referred. One could be that, so the child has been referred, you have made that referral, the family gets contacted, and the family can't be reached. They never pick up their phone, the phone number is not good, messages are left, and there is no follow-up from the family to actually establish additional contact. So those families may not, by the first time that they're referred, take that offer. And you may see them in your practice again, and you may have to do that referral again for them. There are many other barriers, and I will talk about them in a minute, to why there might be a delay. But I think the important message here is just because somebody has not followed through to EI, continue to refer or talk with them about their concerns and explain to them how early intervention can really be helpful to their child. Next slide. So we also have the Early Childhood Home Visiting Program. Again, here's the link that is provided. Again, a wonderful website, really easy to navigate with great information. Going to the next slide, please. So what is kind of home visiting and how is it different from early intervention? If you think about home visiting, it is really a two-generation program. So home visiting really targets the parent, family member, as well as the child. Home visiting also can begin during pregnancy and then go through the child's early life. Home visiting, different to early intervention, can serve expectant families or caregivers of a child under the age of 2 whose income is not in excess of 200% of the federal poverty level. So here we actually have an eligibility criteria based on income, which we don't have for early intervention. There are other specific eligibility criteria based on the different evidence-based models that are provided in Ohio. Home visiting is available to families in all counties in Ohio. And what home visiting is doing is really supporting parent-driven, family-oriented self-sufficiency building goals. So it is really to empower the parent to learn how to best parent their child, to help the family be independent in monitoring their child's development, as well as helping their child in their development. There's also collaboration with other social service coordinators and lots of information and education about early childhood growth and positive parenting for the families, in addition to also helping them with direct, teaching them how to play with their child or how to help their child in their development. Also, the home visitors conduct health and developmental, environmental, and relationship screening. So it also looks out for these families to ensure that there is a positive and healthy family environment for the child to develop in. Next slide. You can continue. Next slide. So as I mentioned earlier, there's a variety of barriers why families don't necessarily take the first referral that has happened to them. We know that minority populations are at greater concern for how the government might treat them. There is, fear of bias and discrimination. So that might be one reason. Socioeconomic factors. We know that some families, lose their phone service or move around a lot or don't have a specific home address because they're homeless and just moving from family to family member. So that could certainly be a barrier. Just other caregiver factors in terms of having too many responsibilities, just not being able to follow through, having basic needs that the family needs to meet first, like food and housing, before they can even think about their child's development. And then certainly with COVID-19, we have seen many different issues in terms of people losing their income and people just struggling in general. So not being able to make early intervention or home visiting their priority. So how can you actually refer to early intervention or Help Me Grow? I love that there are many different ways in which you kind of get to the same place. So for both home visiting as well as early intervention, the intake line is a 1-800 number. There are also regional and local early intervention numbers. And I think I have a slide in a moment that shows you how you can get in touch with those. There is, go back a step, sorry. So there's a referral form online that you can fill out. And there's also an email address, Help Me Grow Referrals at helpmegrow.org, that you can utilize to make your referral or have the family make the referral, or where a teacher can make a referral. Really, this is open to anybody to make a referral to early intervention. And then there will be a follow-up to the family directly. So that's a very easy way to do that. And Steph, if you go to the next slide. So this is on the website, and you can actually click on the different regions, and you see also the like your regional local numbers listed there to go to the more localized supports and services. But it all ends up in some ways at the same place, so that families can easily be referred and then receive the services that they need. Next slide. So we have talked also a lot about our Learn the Signs Act Early initiative. So we want to make sure that you know where you can go to find some of those free materials. So we have an Act Early specific page on our USAID website. And relatively new, we have the Act Early Ohio order form, which you can just click on the link and it gets you right to our website and the ordering form, where you will see the different materials that you can order. You can put in if you need them in Spanish or in English. You can also say in which quantity you want those. We can put that together. We pull all the information together and then create individualized kind of bags for each family, and we can ship that out to you. All of that is available to you for free, so there's no cost associated with that. And of course, we would love to see more physician practices contact us and order those materials online. You can also email us at any given time if that is easier for you to let us know what type of materials you would like. We are on social media. You can follow us. You can send your families there. There's going to be lots of great tips in terms of how to support the children in their development. Here are just our references that we use throughout the presentation. And I think we have maybe a question and answer slide at the end. And I know I saw we have some of our colleagues from Bright Beginnings with us, and I saw that they already answered some of the questions in the box, which is great. So there's lots going on in the chat box I see. Let's see, I just want to make sure that we answer all of the questions. So again, early intervention is not really a therapy or treatment program per se. It is really coaching based. So let's see what else we have. Okay. Yeah, I'm sorry. I'm just going to go through the questions in the chat. Oh, that would be great. I don't know, Steph, do you have easy access to put the links for Act Early materials in the chat box?
I put our website in there.
Okay.
And I put our Jot form link in there, and then the Act Early materials website, I will, from the CDC directly, I will drop in as well.
Great. Any other questions you have for us? If not, I will send it back to Alex to close us out, I think.
Great. Thank you all so much for taking the time to speak with us today and share that information. If any other questions come up, please feel free to send me an email and I can pass those questions along to our speakers. I sent the link to the survey in the chat box. I also sent an email for that post-evaluation survey as well. And that's how you will receive your CME and MOC Part 2 credit. And then I also put the resources that we have available as well as the registration link to our trainings that are coming up. Our next one is in April on trauma-informed care and ACEs. So we are so excited to share that information as well. And again, please let us know if there are any additional questions. And we are so glad that you were all able to join us today. We had a great turnout with almost 70 attendees.
Thank you for having us.
Yes, thank you both all so much. We really appreciate it.
Thank you. Have a great rest of your day.
Have a great rest of your day.